Claudia C. Craighead, Jr., Professor and Chair of Vascular Surgery at the Louisiana State University School of Medicine. He's also the Program Director of the Vascular Surgery Fellowship and Integrated Vascular Surgery Residency. In addition to these roles, he's the Vice Chair-elect of the Vascular Surgery Board, Secretary and Treasurer of the Associate Program Director, Academy of Program Directors of Vascular Surgery, and co-chair of the Wellness Committee at the Society of Vascular Surgery, and Chief Medical Editor of the Vascular Specialist. Thank you, Dr. Sheahan, for joining us.
Thank you. Good morning. I have no disclosures. Before I begin, I want to thank Dr. Ross and the committee for bringing my wife and I here. Many years ago, after Hurricane Katrina, my wife and I were the only faculty in vascular surgery left at LSU, and I remember going to a meeting, national meeting. Nobody really knew who the hell we were, and so we're just kind of sitting there quietly watching the talks, and a guy comes over to us, and he's like, "You're from LSU, right?" I said, "Yeah." I graduated there. Say hi to Dr. Batson, say hi to, and that was Dr. Ross. So Dr. Ross is actually the first person to ever come up to us at a meeting and recognize where we're from, or either of us. So it's been a long time, but thank you, Dr. Ross, for all of that. So I'm supposed to talk to you about aneurysm screening, but there's several problems with screening. And one of the first I want to address is literacy. The public doesn't know what an aneurysm is. And I'm going to show you they don't even know what screening really is. So trying to convey that we want to screen you for aneurysms is kind of a double negative to them. So health literacy is very important, and it's very, very tied to how people actually take care of themselves. So the average literacy level in the United States is 8th grade. We know that. The NIH recommends that in all our literature we print at about a 6th grade level. But a lot of studies show that about a third of the population in the U.S. has inadequate health literacy. So again, literacy is an important predictor of health status, and low literacy patients will have worse illness severity, increased hospitalizations, and decreased adherence to our recommendations. So what about aneurysms and literacy? For some reason, this has been one of our greatest failures, I think. We know that there are 15,000 ruptured aneurysm deaths a year. We estimate from the autopsy counts that there's another 15,000. So our yearly mortality is about 30,000 from ruptured aneurysms. But very, very few people in the U.S. know that. What they do know is prostate cancer, right? But the mortality is about the same in the U.S. 32,000 people die a year of prostate cancer, and about the same die from ruptured aneurysms. Yet we have failed to inform the public of this risk. And look at breast cancer, which every person obviously knows what it is, and it's not that many more people who are dying from it. So again, this is a failure of us to effectively communicate this to the public. So in building a screening program, the government's first question is, what's it going to cost? And so their model, it's called a Markov model, and it's cost per quality adjusted life years saved. So when we want to convince the government to pay for this, we have to look at what else they pay for. So probably the highest cost item that CMS will ever cover is dialysis. So dialysis costs about $54,000 per quality adjusted life years saved. Cabbage is about half that, but still on the more expensive end for what CMS will reimburse. But then if you look at screening things like mammography, it becomes much cheaper, and we have shown that aneurysm screening is almost half of that. So aneurysm screening is very cost effective, yet we've had such a hard time convincing the government to broaden the screening criteria. So I first started looking at health literacy. Dr. Zimmerman there is a PhD from UNO. He's very involved in healthcare policy. So he brought us this validated model for assessing literacy. So we did this at some of our aneurysm screenings, and it's basically you start with a word, and then you give 2 other words, and you're supposed to say which one it's most like. And again, this is a validated system of testing literacy. I didn't love it, but we did it. And what we found is that people actually don't know the words asymptomatic, and they don't know what screening is. And so that was pretty worrisome. Also, only about half the people knew what an aneurysm was. The other problem is, as I learned in literacy, there's 2 things. You can not know what something is, or even worse, you can be actively wrong about what something is. And that's where asymptomatic screening and cholesterol come in. People think they know these words, but it turns out when you ask them what they are, they don't know what it is. So it's this false confidence. They have poor understanding or poor literacy for words like dilation and aneurysm. So again, very hard to convey to them what to do when they don't even understand what we're talking about. So when we look at age over 60, our patient population basically are more likely to perform under the mean in literacy tests. And so again, these findings were performed at a literal screening event. And so the people there didn't know what screening meant. And it was an aneurysm screening, and they didn't know what aneurysms were. So these are probably the highest literate group we're going to find because they actually presented to a screening event. So this is probably the highest boundaries of literacy that you'd find in a cross-section of the United States. So there's a lot of studies on literacy in almost every specialty except ours. We had one of the first. But I didn't like the model that you take a word and you choose one. I wanted to account for the fact that people could admit when they didn't know what a word was rather than have that guesswork involved. So we devised a new form, and we went to our consent forms and picked words out of there that patients are expected to know. And so we found 24 words that I thought, well, maybe they probably don't know what these things are. But the first option always on everyone is, I don't know. So we don't have that kind of false confidence or even false guessing confounding our outcomes. So we had actually a VFW convention. We had a mass screening event, and we screened 1,000 veterans for aneurysms at New Orleans over a weekend. So we used that to try to do this early literacy form. Again, this was a veteran population, so it skewed white, male, and older. But what we found, only 20% were even literate in what our terminology was. People knew what stents were, they knew what an aorta is, and they knew what dialysis was, but they didn't know what fistulous, claudication, or ischemia was. And probably most importantly, they thought they knew what aneurysms were, but they did not. So people think aneurysms are things other than what aneurysms actually are. There was no association with gender, although females tended to do better. And there was an association with education, but education had no predictive value. So there was some other factor here in determining health literacy other than the actual obtaining of higher education. So literacy is predictive of health status, and this is, a novel method of assessment. And what I wanted to translate this to clinic, but at the time I became interested in other barriers to healthcare, and so we've kind of devised this survey along with assessing trust in physicians and patients' resources to kind of a broader examination of our population in New Orleans. So we don't have outcomes of that yet, hopefully by next year. So that brings us to screening. So this is the current USPSTF recommendations, and similar to what Dr. Upchurch showed you, we don't have a lot of good evidence, and we only have a B grade for men, 65 to 75 who've ever smoked, and that's why our screening guidelines are so restrictive. But the problem is that all of this is based on basically 4 trials. All the trials were conducted outside the United States. Most of the participants in the trials were male. Almost all of them were over 65 years old, and all of them were performed over 20 years ago. So all of the data that the government used to determine who screened aneurysms in this country is outdated and probably inappropriate. So the SVS has broader guidelines, which is great, right? Except that insurance companies don't really care what the SVS says. So SVS guidelines can be broad, but until CMS comes along with it, it doesn't really matter. But the SVS does recognize that women need to be screened as well, whoever smoked. Obviously, if you have a first-degree family member, male or female, you should be screened. And then women with a history of tobacco use over 75, men or women, should be screened once. So the CMS guidelines are pretty strict. So male 65 to 75 with a history of smoking, or men and women with a family history. The trouble is that we're missing a lot of aneurysms, and Dr. Milner's group looked at the epidemiology of fatal ruptured aneurysms in the US, and he found that only 57% would have even been eligible for screening by these current criteria, and that 34% of the fatal ruptured aneurysms in the country are in women, and 10% are in men too young for screening. My friend Dr. Schermerhorn actually had another interesting study looking at the VQI, and what they found is that the percent of ruptured aneurysms in these patients who were ineligible for screening, so in women, 90% of women who died, or presented with a ruptured aneurysm would have been ineligible for screening. 64% of Black individuals who presented with a rupture would have been ineligible for screening, and 85% of Medicaid patients who presented with a rupture would have been ineligible for screening. So our current guidelines exclude women, minorities, and poor people. So that seems problematic to me. So we have to push forward. So again, cost effectiveness, what are they going to pay for? So there's been some studies out of the UK. Now the UK, they're always kind of contrarians when it comes to aneurysms, right? Standard of care in the UK, Mrs. the Irish in me coming out, I think, but they still recommend open repair for, routine infrarenal AAA. So they did some screening, again, male 65 to 75, and found a prevalence of 1.5%. But most important from this study was their cost-effective conclusion. And so screening with prevalence of 1.5% is cost-effective, but more importantly, the threshold for cost-effectiveness in aneurysm screening is probably much, much lower than that, and probably about 1/3, 0.35 to 0.5% prevalence will be cost-effective in screening. Further studies are kind of, this one I don't agree with, but basically they're saying that the prevalence in women in that age group was about 0.43 to 0.7%. They thought it was not cost-effective to screen them, but they did admit there's considerable uncertainty doing that, mostly because they were uncertain about the AAA prevalence in women, because it hasn't really been studied. So we set out to do an all-inclusive aneurysm screening program in the US and analyze those results and identify subgroups that should be screened. So we paired with Aneurysm Outreach. Aneurysm Outreach was formed actually without a medical director, which was fortunate because they screened people they probably shouldn't have been screening. So their results are kind of compelling. So it was all, you showed up and you got screened, man, woman, child. So they screened everybody who came. Once I became their medical director, I started saying, well, wait, I don't know if we should be screening, these 30-year-old women. But we did find a few aneurysms, so I'm going to show you that now. Unfortunately, the pandemic caused Aneurysm Outreach to shutter permanently. I'm trying to find them a home somewhere within the SVS at some point. But they conducted these free, open-ended screenings through a lot of states all around the country. I found good data in about 10,000 patients. These were questionnaires they filled out, so a lot of them didn't fill out the questionnaire. Some of them clearly didn't understand the questionnaire. But I found about 10,000 of them were good quality data to use. And compelling, more than half of the participants were women. Women go to screenings. And we found that, if you open up a screening, more women than men will come. The women will drag the men with them, but men don't generally go to screenings. So we had only 41% of these people within the current screening guidelines ages. So 60% were outside of what's currently recommended. I think we should get away from race and ethnicity as a determinant aneurysm. I don't think that really exists. So we're empowered to study it. So I won't address any racial discrepancies in aneurysm prevalence because I'm not really sure it exists. Clearly there's a difference between men and women, but this is kind of, these are your routine screening. Well, who do you get at screening? You get your general population. You don't get super sick people, right? People on dialysis, people with terminal cancer don't go to screenings looking for more problems. So you get, kind of a cross-section of the United States there. And what we found is that 3% of all people had an aneurysm. That's all comers, much higher than you would have thought. And 43% happened within that screening. So the majority of patients we found aneurysms in would not have met screening criteria. And if you look at it, a lot of them happened at age 55 to 64. Now, some of the characteristics are typical. Male, obviously, odds ratio is high, smokers, ever smokers. But if you look around, you see that throughout, there's a relatively high prevalence of aneurysms in almost any population you look at. Obviously higher with age, obviously higher with smokers, but it is compelling evidence that these exist well beyond our screening guidelines. And if you look at obesity, there is a weird effect of obesity, especially in women with aneurysms. I'm going to skip ahead forward because this is going on a little bit long. But what I want to tell you is that all of this is based on logistic regression. Logistic regression statistics assume a lot of things, but machine learning doesn't. And we're trying to address that big I, that the U.S. Screening guidelines have, inadequate evidence. So if we look at what the recommendations are, they need more studies, and they need ways that they can risk predict people outside of these screening things. So we aim to look at how are we going to get outside of logistic regression, look at machine learning, and get a machine learning model that you can use in your clinic. So a lot of this now is meant to show you that I know how to create a machine learning model. But Dr. Long told us to be humble, so I'm going to admit I have no idea, despite me circling that number, how to create a machine learning model. So we actually used an engineer. But what I wanted was this. So you have a patient in your office, you put these things in, and you will get a number. And machine learning can give you that. And they can just put in, female cardiac disease, and you will see that there's a relationship with these risk factors that we can't really account for with standard statistics. Some of these risk factors, like, I'm going to skip ahead to women here because that's more interesting. The men stuff was fairly standard, but look at the relationship with BMI. It's nonlinear. So there's a relationship with obesity in women that we never really kind of addressed before. And so it's only when you put this machine learning model into effect that you can kind of graphically demonstrate that we're not capturing a lot of this stuff in women. Men, it's much more linear. So again, we're highlighting that women have a very complex relationship with aneurysms that we're not really capturing with our current statistics. And we really need to kind of figure out these likelihood groups so we can screen better. But probably most importantly, we need to expand the screening criteria, we need to provide evidence, and we need to get people to come to screenings. Only 1.4% of people eligible for aneurysm screenings actually get them. And so if you're going to go back to that cost-effective model and cut off at 1% who should be screened, well, women who've ever smoked over 65, men, anyone over 65, men who've ever smoked over the age of 45, and healthy males and females over 75. That's if it's at 1%. But as some of the studies have shown us, if you say it's cost-effective at 0.5%, then any male or female over the age of 55 should be screened in the U.S. for aneurysms. Thank you very much.